Hi, my name is Alex Berry and I am from North Shore Hospital. I'd just like to say thank you to the Nuclear Medicine Department at Royal North Shore Hospital, particularly the supervising consultants Dr. Jeremy Huang and Dr. Jeff Shembry. And I'd also like to thank Chong Mo Koo, who was the Nuclear Medicine Advanced Trainee in 2021. This study is titled The Utility of Pertechnetate Screening in Postpartum Radioactive Iodine Breast Uptake. As a bit of background, the radioactive iodine ablation is a well-established therapy after thyroidectomy for differentiated thyroid cancers. Sodium iodide synporters are what allows the bioconcentration of iodine in thyroid tissue and allows for targeted ablative therapy for residual carcinoma. We know that there is high breast uptake described in women who are breastfeeding or have recently been breastfeeding or recently pregnant. And at our institution, we use a screening technetium-pertechnetate study to identify women at risk of significant breast uptake, allowing us to delay their ablation, potentially repeating the screening study, overall to minimize risk of RA uptake. We know that the NIS, or the sodium iodide synporter, is regulated by prolactin in the breast, and this can be downregulated by ceasing breastfeeding or by dopamine receptor agonists such as cabergoline. The calculated exposure of a lactating breast to a 4 gigabecquerel dose of radioactive iodine 131 has previously been demonstrated to be equivalent to about approximately 1.6 sieverts, which is significant. It is associated with a relative risk increase of 1.67 in terms of breast cancer. So in terms of the thought behind why this institution does screen pertechnetate is it really does, again, provide us opportunity to identify these women who would be at risk of significant uptake. Because images like the one here on the right are too late. Once you've seen that uptake, that's already there in the breast. Our study is a single center retrospective cohort study. We identified women who presented for pertechnetate screening prior to ablation within 12 months after pregnancy. Breastfeeding risk cessation was recorded as the date of known cessation or the date of delivery if the woman never commenced breastfeeding. A visual score was assigned to each study, both pertechnetate and RAI, and representative measurements were taken within region of interests, which I will describe. So the visual score was from 0 to 3. Grade 0 was equal to background uptake, grade 1 greater than background, less than liver, and grade 2 equal to liver, grade 3 the highest grade being greater than liver uptake. The grade is given to the highest single focus in terms of the 20 millimeter region of interest. We recorded both the average mean counts and the average maximum raw counts compared to the internal control of liver and axilla. And in terms of the scores, here is an example of each of the scores. You can see in the first example, there is almost no uptake in breast. There's an appreciable shadow perhaps here. Slight increase in grade 1, grade 2 equal to liver, and grade 3 demonstrably higher than liver uptake. In the 10 years to December 2020, we identified 39 patients, excluding 5 for data that was unretrievable for reconstruction, 1 patient who was not proceeding to ablation, at least at our institution, and then 1 patient who we did not have enough data retrospectively to include in the study. Overall, we had a patient population of 32 with 38 pertechnetate scans, either initial or repeat, and 32 ablation scans. So we'll have a look at the results and some demographics of our population. The average age was 33.9, with the following thyroid cancer subtypes of papillary, follicular, and Hürthle cell. The average time between breastfeeding cessation for the pertechnetate and then the ablation scan were 110 days and 127 days respectively. And overall, the ablation dose average was 3.3 gigabecquerels with a range of 1 to 6. We can see that the majority of patients presenting for their pertechnetate study were before 4 months after ceasing breastfeeding, whereas the majority of the ablation scans were actually after 4 months, 66%. You can see here that the use of dopamine agonists was heterogeneous, and we have not analysed this further. So in terms of the visual scores, the pertechnetate studies demonstrated 89% of patients with a score of 0 or 1, which is great. 3 patients had a grade 2 and 1 patient had a grade 3. For our radioactive iodine ablation studies, 94% of our patients had a grade 0 or grade 1. So 89% of our pertechnetate scans had low uptake. 30 out of the 32 of our RAI ablation studies demonstrated low uptake also. The remaining 2 of these patients had grade 2. These are the 2 patients that we saw with the uptake that had scored grade 2. Again, I just remind you that we had the highest avid focus of each breast or breast tissue. And you can see that although that yes, there is a definite increase relative to the liver, relative to the background but equal to the liver, the majority of the breasts on both of these patients is generally low. The next slide demonstrates the raw counts projected over time, with the green lines delineating whether or not it was 4 months or before or after 4 months. The blue markers represent pertechnetate studies and the red represents ablation studies. And you can see generally that the pertechnetate studies were earlier and slightly higher in terms of their raw counts compared to the later and lower raw counts on ablation. Unfortunately, it is a very heterogeneous group with multiple doses of radioactive iodine. So the raw counts in and of themselves are not particularly useful. As far as subgroup analysis, women who received 4 gigabecquerels were by and away the largest group, with 18 out of the 32. There is a significant correlation that we've demonstrated between the iodine and pertechnetate studies when we compared the ratio of the breast count mean to the liver count mean, and that was linear with a significant p-value. There was a trend also seen in terms of being able to correlate our pertechnetate screening scan to our ablation using the breast to axilla mean ratio. However, this was not statistically significant. And neither of these comparisons were significant across the entire non-corrected or non-subgroup analysis. So we have an interesting subgroup of patients who had multiple pertechnetate scans in terms of the 38 total scans with the 32 patients. 1 patient required 2 repeats and 4 patients required 1 repeat. We saw that the majority, 4 of the 5 patients, had decreasing uptake over the repeat studies. 1 patient had increasing ratios. Now this is looking at the breast mean to axilla mean and the breast mean to liver mean. So we've just picked out the raw images from the detector for that patient that showed increased uptake. And on the left we have the first screening study, the middle imaging is the second screening study, and the final image is the whole body sweep for the post-ablation study. There is decreasing activity that we can see visually. So we think that although the quantitative measures can correlate as described, the visual score is probably more useful because by the time that it was by the time of the ablation scan, there was clearly very insignificant breast uptake. We showed that there was a statistically significant difference in the counts between the breasts before 4 months and after 4 months, particularly for the iodine scan. And we're just going to go on to discuss a few results. Our study showed that we showed a statistically significant correlation between pertechnetate and iodine uptake, particularly looking at that breast to liver ratio in the 4 gigabecquerel group. We didn't see this correlate across the whole study, and we think that given that there was a small number of patients and variability in their doses, this was likely confounding and unable to be corrected for. The majority of our patients, 89%, had pertechnetate breast uptake equal to background or less than liver, and only 2 of the patients who had high-graded RAI likely overestimated due to the ROI at the focal avidity. No patients were considered high-grade, grade 3 at RAI, and that's really important. None of our patients were in that really dangerous territory of significant breast dosing. We observed higher breast uptake in the ablation that was completed before the 4-month mark compared to those completed after 4 months. We saw that 5 patients required repeat scanning with decreasing uptake over time in the 4 out of the 5, and noting that the visual score for the remaining patient was actually less over time. And again, just to remind you, we do see that there was grade 1 on both scans and really grade 0 by the last study. We know that this study is limited by its size. There's an inhomogeneous group with varying doses, various body sizes that we did not correct for. It's retrospective, and there is definitely unmeasured confounders that we cannot confidently correct for. So in conclusion, a low breast uptake by visual assessment at a pertechnetate screening scan correlates to a low risk of significant breast uptake on a post-ablation iodine scan. We can't comment on a safe level of pertechnetate screening because we didn't see a high or an inappropriately high level of uptake at any of our iodine studies. And we know that there is significantly lower uptake when ablation is performed after 4 months. Just to remind, our worst uptake score at ablation is shown on the left and does not correlate at all to that significant uptake on the lactating woman seen. And just in terms of a comment on the dose implications of performing these screening pertechnetate studies, given a 125 megabecquerel injection of pertechnetate, that would impart to an adult, no specific gender, an approximate effective dose of 1.6 millisieverts. Compare that to the worst case scenario of the effective dose to the breast of 1.6 sieverts. So, in conclusion, we believe that the visual scoring of pertechnetate screening is a safe step in reducing the risk of significant uptake of ablation therapy at the breasts of postpartum women.